All right, so I'm going to go ahead and get started, just to be mindful of all of your time who are logged on. And just so you know, this session will be recorded. So if you want to share it to anyone or look at it later, you'll be able to view it later. So I'm Emily Myer. I am a urogynecologist, or female pelvic medicine and reconstructive surgeon, or surgery is another name for the specialty of urogynecology. It is a boarded subspecialty of since 2012. And so it's been, in terms of all of medical specialties, a fairly newer specialty, but now it's been going on for almost 9 years. So I'm originally from Minnesota, and I grew up in Minnesota. I did my, high school here. I went to college in Gustavus, and then I went on to medical school in Albany, New York, at Albany Medical College. And then I did my residency in obstetrics and gynecology at Eastern Virginia Medical School, which is in the Virginia Beach area, Norfolk, Virginia area, and did my fellowship in urogynecology and female pelvic medicine reconstructive surgery, which is a 3-year fellowship at Johns Hopkins University in Greater Baltimore Medical Center. And we're joined on the call today by 2 individuals from Medtronic, Sarah Retka and Courtney Applequist. So thanks to them for helping coordinate this event for tonight. And thank you all for joining. So the presentation tonight, let me see, my slides are advancing, there we go. So the presentation tonight is mainly to talk about our bladders and how they can be so bothersome. So 44% of people are embarrassed to talk about their bladder control problems. And a lot of women spend time kind of thinking about being able to do activities related to, is there going to be a bathroom there, or they're going to have to cut their exercise routines down because they're not going to be able to go for that hour walk because there's not a bathroom on the way. Related to COVID, I had another patient say that, all the public restrooms were closed, and so she had to stop exercising because she couldn't go to the bathroom on her walk. So it's a real problem, and affects, in addition to being a bother, it really impacts our activities in our lives. And it's important to know that you're not alone, and there's a lot of women with bladder issues, and there's a lot of providers out there who can help you. So, Medtronic's theme statement, so to speak, is life without limits. So being able to do what you want to do without being limited by your bladder controlling that for you. So having control over your bladder. So the goal of our talk is to kind of talk about, or the agenda is to talk about what is bladder control and what are the normal aspects of bladder control. And then we talk about the care pathway. So what are the treatment options for managing what we call overactive bladder? And then one of those advanced therapies is made by Medtronic, and that's Sacral Neuromodulation. And so we'll go to that therapy as well. And then at the time, there will be time for some questions and answers. So during the presentation, if you have any questions, you can just type those into the question and answer portion of the Zoom call, and we'll answer those at the end. So again, you are not alone. Overactive bladder is very common, and 1 in 6 adults have overactive bladder. It affects women and men of all ages, but does seem to affect women disproportionately, and also older women. So it tends to increase in frequency after menopause or as women get older. It can cause issues with waking up at night, causing problems with loss of sleep. So some women may wake up 3, 4, 5 times overnight. And then, there can be loss of confidence and self-esteem, some isolation, so to speak, because you always need to be by a bladder and want to be closer to your home, which is easier now, right, with COVID than it maybe was a year ago, but not something that we want to keep up in the long term if we can avoid it. And also associated with feelings of, generally poor health. It's very common, so it will affect, about 37 million adults in the United States, and that's, on par with those numbers affected with diabetes. So let's just talk about kind of what is normal. So what we call overactive bladder is kind of a compilation of symptoms, including increased urinary frequency, urgency, feeling like you have to go now, and sometimes even leakage and urge-related leakage, where you're feeling like once you feel like you have to go, you're not going to make it to the bathroom on time. So on average, women or people go about to the bathroom about 8 times in 24 hours. It should be that when you feel like you have to go, you should be able to finish the activity that you're doing before going to the bathroom. So that may not mean waiting an hour or two, but even being able to wait 5, 10, 15 minutes to finish what you have to do before you feel like you have to drop everything and go. Not having to plan your activities around the bathroom. A lot of people will cut down on how much they're drinking or really avoid drinking to avoid having to go to the bathroom, which can have impacts on other aspects of the health. So if you're modifying a lot of your activities around your bladder in the bathroom, that kind of signals that there's a bladder problem going on. So normal function is that the bladder, which is depicted on this image kind of at the bottom of the body, the white, sends a signal to the brain when it starts to get full. And that brain will signal back to the bladder and send a nerve signal to the bladder that it's either okay to empty, meaning it's an appropriate place and situation and you're near the toilet and the bladder can contract and empty. Or it could signal to the bladder that, oh, you're in the middle of something and you need to wait, and it should stop that bladder spasm or the bladder contraction from happening. The communication between the bladder and the brain really is the essential part of bladder control. And if there's a disconnect in that signaling, that's what can cause bladder problems. So there are some lifestyle things that can impact our bladder control problems. So some of it may be impacted by our daily habits, what we're eating and drinking, medications or supplements, or even injuries related to childbirth. So when we think about, in terms of what we're eating and drinking and that impact, things that tend to be caffeinated like coffee, tea, sodas can make the bladder more likely to have spasms and stronger urges that can be harder to control. Additionally, medications, so specifically diuretic medications that may be used to treat high blood pressure or impact swelling, can make you make a lot of urine in a shorter amount of time that can be harder to control. And then there can be injuries are related to pregnancy and childbirth. So maybe those muscles are weak or torn and you don't feel like you have this squeeze to be able to hold in and stop the flow of urine or be able to control the urge when it comes. Or maybe there's an issue with the bladder prolapsing or other things that can impact your bladder emptying that can contribute to bladder control problems. So when we think about bladder control problems, there's 3 primary things to consider. So the first thing is what we call stress incontinence. Secondly, urinary retention can be a problem, and oftentimes the symptoms for urinary retention are very minimal, and you may not know you're not emptying the bladder. And then finally, the overactive bladder. So stress incontinence is primarily an issue with activity-related leakage. So that's going to be when you cough or sneeze or maybe doing more impact activity like running or jumping, exercising. And that's primarily from some loss of support for the urethra. And the biggest risk factor for that is having a vaginal delivery. Just impacts the control of the urethra and the support of the urethra. Secondly, urinary retention is when the bladder doesn't empty all the way. And so I have a lot of patients who come in saying they feel like they're not empty. And I usually try to kind of gain more information about that. Is that feeling of not emptying because after you've gone to the bathroom, it feels still full? Or is it that you kind of immediately have to go to the bathroom again and there's increased frequency? And so some of the symptoms between urinary retention and overactive bladder have a little bit of an overlap. And the way that we diagnose urinary retention is by measuring how much is left in the bladder, either through a catheter to empty the bladder or a little ultrasound of the bladder to see how much urine is left. And then thirdly, overactive bladder. We kind of discussed this a little bit, but that's mainly related to frequency, urgency, and then the urge-related leakage. So we kind of talked about, what is stress incontinence, and it can be really varying degrees of activity that can cause leakage. So for some people, it's just with, more strenuous activities like doing CrossFit or playing tennis. Other people, it's with really minimal activity like bending over or picking something off of the floor. And with stress incontinence, sometimes you'll, by habit, kind of keep your bladder empty to prevent it from being too full and leaking too much with those activities. Urinary retention is if you're unable to empty the bladder. And some of the symptoms of this could be a weak stream or maybe a dribbling stream where you feel like the stream of flow of urine is really slow. Some some patients with urinary retention use a catheter to empty the bladder. And then overactive bladder, we kind of discussed is, having leakage of urine related to the urge, feeling like you have to go, but not being able to get to the bathroom on time. And maybe even using pads to protect or just in case, or having an extra pair of clothes in your car or your bag in case you have any leakage episodes that you might need to change. It's usually associated with frequency where you're going more than average and that urge is severe and you can't suppress it or let it go. And kind of the urge is difficult to defer. Sometimes it's the feeling like your bladder's never empty because as soon as you've gone, you feel like it's full and you have to go again. Or you're modifying your drinking to avoid the bladder from getting too full. But overactive bladder treatments can get you back to kind of not letting the bladder control you and living your life. So when we think about overactive bladder, we just kind of want to confirm the diagnosis. And then the first line treatment would be doing lifestyle changes. And we'll talk about those in more detail. There's also medications that you can use to control them. And then there's advanced therapies. So when we think about the diagnosis, there's some things that we want to make sure aren't causing or mimicking the symptoms of overactive bladder. And that's primarily a urinary tract infection. And so usually when you come in for evaluation of overactive bladder, we just want to look at the urine to make sure it doesn't seem like there's an infection going on. When we're younger, symptoms of a urinary infection tend to be more consistent or maybe stronger, and that can be burning with urination, frequency, bladder pain. As we get older, some of those symptoms get a little more vague, and it may be just that you have more frequency or more urgency. So it's important to rule out and make sure there's not a bladder infection going on. Other things that we want to assess at the time of the diagnosis is to make sure anatomically there's nothing going on like prolapse or any neurologic symptoms that could be causing the overactive bladder symptoms. And then finally, related to the diagnosis, usually also checking the post-void residual, meaning making sure that you're emptying your bladder okay by measuring how much urine is left after you've gone to the bathroom, just to make sure that there's not any urinary retention that we said can kind of mimic those symptoms of the overactive bladder with the frequency and the urgency. So when we think about lifestyle changes, there's some simple solutions that can work well. And for some people, these can be significant improvements in their symptoms, and for other people, may not control the symptoms. So, oops, sorry about that. So some simple solutions could be related to dietary changes, decreasing the caffeine, especially the soda, which is, big bladder irritant. So, decreasing your caffeine intake by 25 or 50% can significantly improve the sense of urgency and frequency. In terms of kind of total amount of fluids, I have some patients who come in and they're drinking almost a gallon of fluids a day, which is a lot for your bladder to handle. So generally we say aim for around, 60 to 70 ounces of fluids a day, especially if you have fruits and vegetables, things with natural water content, soups. You may even need a little bit less than that. So drink to your thirst, not to necessarily meet a certain number. The other thing that can be really helpful is exercise and diet. And the reason those are helpful is that we know that weight loss can also improve overactive bladder symptoms and leakage. So women who are overweight and lose 8% of their body weight have a 40% improvement of their overactive bladder symptoms and urge leakage. So there can be significant improvements, but we certainly know that losing weight is really difficult. So it's not easy, but if you have any incentive or been looking for an incentive to, get back on exercising and eating healthy, let it be your bladder. And then finally, physical therapy and strengthening the pelvic floor muscles can be really helpful also for overactive bladder and urge leakage. And so kind of for the same reasons that we talked about, when you can kind of squeeze around those muscles around the urethra, you're sending a signal back to the bladder to relax. So it's all part of that nerve pathway. So strengthening the muscles of the pelvic floor, specifically biofeedback, kind of making sure that you're squeezing them correctly and working with a pelvic floor therapist can also improve bladder symptoms. If those things don't work, or if symptoms maybe are too strong or you're leaking too much to be able to manage while you're working on strengthening the muscles or making some of those dietary lifestyle changes, medications can be helpful. So medications are usually a pill that you take every day. Some side effects of the most common medications can be dry mouth, blurry vision, or dry eyes and constipation. So that's the main class of medicines called anticholinergics. And there's a variety of medicines in that class. Some may also be associated with memory issues. So I have a little more hesitancy about those medications, especially in my patients who are 60 or older and may have, some risk of dementia just related to age or some memory loss. And the other medication is called a beta-3 agonist. And that medication may be associated with elevation in blood pressure. Not commonly, but it's something that we need to monitor. So when we think about medications, the goal of the medicine will be to reduce those bothersome bladder symptoms by about 50%. So 50% less leakage episodes, 50% less trips to the bathroom, or urgency severity. The problem with medications is there's a high discontinuation rate. So that can be from a lot of factors. One can be cost. Some of the medications, especially the newer medications that may have less side effect profile, tend to be expensive and not well covered by insurance. And so, these medications can be $300 for some patients, which is just unreasonable. Other medications can have side effects that aren't tolerated. So that could be worsening constipation or dry mouth that makes them not be able to continue taking the medicine. So a lot of patients, meaning more than 50% of patients, have stopped taking their bladder medication at 6 months. That's not to say it's, all patients, 30% or more are continuing, medications because it's effective and side effects are controlled or not bothersome. So for patients where lifestyle modifications don't make a difference or medications either aren't tolerated, limited due to cost or side effects, there's advanced therapies. So there's 3 advanced therapies to treat overactive bladder. So the first therapy is called percutaneous nerve stimulation, and Medtronic has that, delivers that therapy it's called the Neurosystem. And the second therapy is a inner stim device, also called Sacral Neuromodulation. And then the third therapy is injected medications into the bladder. So we'll go through each of these. So the injected medication into the bladder is done in the office cystoscopically. That means that we put a little camera in to the bladder and we inject the medicine through a little needle into the bladder muscle. And that medicine is going to kind of paralyze the bladder muscle, not completely, but to a degree that it prevents the bladder from having spasms, strong urges, and urge-related leakage. The downside of the medication is that about 5 to 10% of people, it does paralyze the bladder to a degree that they can't empty the bladder on their own, and there's a risk of needing to catheterize yourself. The medicine does wear off over time, meaning every 6 to 9 months, we would have to repeat the injection with the medication. Because it wears off, it's not going to be a long-term need to, keep catheterizing, but there is also some risk of bladder infections. And in some patients, those are recurrent with the Botox or the injected medications. The effectiveness is comparable to oral medication. So again, looking for about a 50% reduction in urgency, frequency, and urge-related leakage. And the continence rate, meaning, the percent of patients that are dry after injection with the medication, is about 40%. The other advanced therapy is called the percutaneous nerve stimulation, or PTNM. And this is, I think the benefit of this one is that it's pretty minimally invasive. So how this procedure works, I'm just going to look to the next slide if there's a picture. No. So how this therapy works is there's a small acupuncture sized needle that is put in the office right behind your ankle bone. And we connect it to a little stimulator that stimulates what we call the tibial nerve, which is the nerve that runs behind the ankle bone up to the bladder. And so it's trying to re-signal the nerve that goes between the bladder and the brain. So by stimulating the nerve, it's trying to increase the awareness or the sensation of that nerve. So about 70% of people respond to this therapy. When you come in for the procedure, you're awake in the office. Like I said, it's just a little needle, so not much pain or discomfort. And you sit there for 30 minutes with the therapy, and we do it every week for 12 weeks. So it does require time, but it's really minimally invasive. The needle comes out and you go home and you come back the next week. So it does significantly, again, reduce urgency, frequency, and urge incontinence. Most side effects, again, are just kind of irritation from implanting the needle, but nothing that would be in the long term. So this is an patient experience with the Medtronic neurosystem. It says, PTNM has improved my quality of life. It's been such a relief to not worry about my bladder needs, and it's a big sense of freedom. So most of my patients who choose PTNM are really happy to do it because it's really minimally invasive. Not a medication with side effects, not a lot of discomfort from the procedure, and you just sit there and read a book while you're having the therapy done. So this is an example of, I should have advanced 2 slides. So this is an example of how it's in. So you can see the small little needle that's attached to the stimulator that goes on the foot. And again, it's 30 minutes in office sessions. And then if you have significant relief, meaning again, at least 50% improvement from the baseline symptoms, then the recommendation is to do a monthly maintenance just to maintain that neural signaling so that the nerve responds how it's supposed to those bladder stimulations. And then the final therapy, kind of advanced therapy, is called Sacral Neuromodulation, or InterStim. So this has been around since the mid 1990s, 1997. And the therapy has changed in some positive ways since it was first implemented. So this is an implanted device that stimulates the sacral nerves. So the sacral nerves are kind of in your tailbone area, and those are the nerves that go directly to the bladder. So there are a few options in terms of the type of device, but the first part is doing a test. So we first do a test. Usually we do it in the office where you're awake, and we just use a little local numbing medicine, and we put a little needle in next to that nerve and the sacral nerve through your tailbone. And we're going to stimulate that nerve to make sure that we're next to it so that we can make sure that we're in the right spot. And then we put a little wire down that needle and take out the needle, and that wire sits next to the nerve. And we have you do a test for usually 7 days. And you're connected that wire to a stimulator. So the external stimulator, which you can see on the picture on the right, is that small little belt that the patient wears. The bandages, there are some bandages on your back to keep that wire in place. And you do a test for a week, and we want to see, at least a 50% improvement of your symptoms. So the benefit of doing this test is that you can kind of try out the therapy through a fairly minimally invasive procedure, just a little needle with a little numbing medicine and wearing some bandages for the week while the therapy is happening. And so again, you can kind of go about your regular activities other than showering for that week. And then you record your daily symptoms. And I would say about 85% of people respond to the therapy and have a successful test where there's at least a 50% reduction in their symptoms. So recently I had a patient who was using 5 to 6 pads a day that were fairly soaked. And after her test, and then she went on to an implant, she's had no leaks per day. So it is possible also to achieve continence even with severe symptoms. So when we think about, this therapy, the benefit of the neuromodulation is that it's really trying to restore normal function by improving those neural communications that are so important between the bladder and the brain. So when we think about satisfaction, about 85% of people are satisfied, meaning their symptoms are improved, and that's even at the 5-year mark after implant. Compared to medications, there's a 3 times greater improvement in quality of life, and that may be related to not having side effects and really not having to do much with the device once it's implanted. And then 76% of people who achieve success with the sacral neuromodulation as compared to closer to 50% with medications. And again, success is that 50% improvement in your symptoms. So before I go through this slide, I just wanted to go back to after the test, what we do is we remove that temporary lead, and then we go to the operating room where you're kind of put under sedation, which is similar to the colonoscopy type of anesthesia. So you're kind of asleep, but not intubated or anything like that. And we put, again, the little needle in your back, put the wire next to the nerve, and then we put a battery or a stimulator that's buried underneath the skin in kind of your hip or butt cheek area. And so the therapy is all underneath the skin, fairly hidden through very small incisions. You may be a good candidate for the Medtronic bladder control symptoms if you've had significant overactive bladder symptoms. The other thing that the InterStim is indicated for that the other therapies aren't is for urinary retention. So if there's a component of I'm not emptying my bladder, the InterStim can also improve the volume that you go with each void and decrease that residual, and maybe decrease the need for catheterization or number of times of catheterization if you've been chronic catheterizing for urinary retention. And then also, you know, if you've tried lifestyle changes and oral medications and aren't satisfied with the therapy, or tired of taking a daily medicine, or those other things we talked about related to costs and side effects, or they haven't given you the treatment, the treatments haven't given you the relief that you wanted for your bladder. So I'm just going to play this video here. Okay. So I just want to make sure the volume is up. Wondering if I should. If it doesn't work in just a second, I may, there we go. My name is Sarah, and I'm a management consultant, and I'm 28 years old. You're right, Sarah. You should be surprised. It's a lot of work.
You may want to increase the volume. We can see the video. Oh, yeah. We can see the video playing, but the words aren't, the volume's not coming out.
Volume's not coming out.
So if that doesn't work,
or try pausing it for a minute to let it buffer.
yeah, that could be.
So I can hear it on my end. So I'm wondering if it's just a transmission issue. Hold on, let me see if I can pause it. Okay, I'm going to close it. Let me see if I can load it one more time. I was just trying to see if there's an option to have words associated with it. Can anyone hear this now? Can you hear the video? No.
Nope.
Nope.
Okay. All right. So I'm just going to pause it. So I will summarize the video. Okay. So so in the video, Sarah was explaining that she was a management consultant and, you know, very involved in her career, but kind of early in life, in her, even at the age of 17, she had frequency and urgency. And she felt like all of the trips she was having to go to the bathroom was kind of impacting her life and her career. And so she had tried other therapies that weren't effective and didn't help her symptoms. So she did undergo the Medtronic implant, and it was life-changing for her. So it is on YouTube. You can also view the video on Medtronic's website. So if you want to kind of get her personal story, and I apologize that the volume didn't transmit through. Okay, so so what happens next? So if you are interested in any of these therapies, there are a lot of providers or specialists that treat overactive bladder, stress incontinence, urinary retention. And so you can find a specialist to help manage your symptoms. So if you have, looking for more information specifically about Medtronic's devices, the Neuro or the InnerStim, they have a really interactive, great website with a lot of handouts and patient videos about experiences that I think is really important in making a decision about your therapy, is kind of hearing what are other people's experiences with it. I can give you my opinion and say, this is my experience with the therapy, that it is life-changing for patients. I just want to go back here to the permanent implant. And the reason I want to go through that is that there are a couple of different options for the permanent battery or neurostimulator for Medtronic. So the lead or the wire that sits next to the nerve is now MRI compatible, and that's a change in the last year, actually. So a positive change that it's no longer a problem to get any MRI. There's also 2 neurostimulators. So one is rechargeable. So that means that just like your cell phone, except much less often, but you just have to put a little charging station over your battery and sit there for about 30 minutes to recharge your device. And the benefit of that is that it's going to make the battery last longer, meaning that battery should last, 15 years or even possibly longer. The battery is fairly small, about the size of a USB or a memory stick. And then the other battery is also fairly small, about the size, of a $50 or so. And that battery is not rechargeable. So that means you don't have that weekly maintenance of, recharging, and you just let the battery drain over time. And in 5 to 7 years, you just go back to the operating room and replace the battery through, a minimal incision with sedation. So fairly minimally invasive, but there are a few new options to the Medtronic therapy since you may have last heard about it. So again, I just want to thank you all for your time. I'm just going to go to the question and answer here about see if there's any questions. So one patient asked, can fibroids affect the bladder? And the answer is fibroids can impact the bladder, and I think a lot of it depends on the size and the location of the fibroids. So when we think about your anatomy, you have your bladder in the front, followed by your uterus, and then the rectum behind. So if you have a very large anterior fibroid, meaning it's kind of sitting in the front, it certainly can be pushing on the bladder and may impact the degree to which the bladder can fill. So fibroids can impact the bladder and lead to kind of overactive bladder type of symptoms. Is there sometimes there's a chat section. I just want to make sure I'm not missing anything here. Okay, all right. So does anyone else have any questions before we end the seminar? Okay, so are these procedures successful with bladder prolapse? So thanks for your question. So when we think about bladder prolapse, there's a few things that we need to consider. And so if the bladder is prolapsed to a degree that it impacts bladder emptying and causing retention, then the InterStim therapy is not going to be effective because that's an obstructive problem going on. So, so essentially, I'm going to use my hand as a little diagram. So if this is the urethra and here's the bladder, and the bladder's fallen, then it puts a little kink between the bladder and the urethra, and that can make it really hard for the bladder to empty. So if we can put that back into place by resupporting the bladder, that may improve bladder emptying. So the answer is bladder prolapse is not improved by any of these procedures. Some people who have prolapse also may have overactive bladder symptoms, and it may be hard to tell if one is causing the other. So is bladder prolapse worsening the overactive bladder symptoms? The answer is it may be, and it somewhat depends on the degree of prolapse. So certainly if things are kind of at the opening or outside, it may have a more impact on the bladder emptying. Sometimes, if someone has prolapse and we're thinking about doing surgery to fix the prolapse and they also have overactive bladder, I kind of say there's a potential for this to improve because we're kind of improving anatomy and putting things back into place. but there's also many women who have overactive bladder who don't have prolapse. And the pathophysiology, meaning kind of the neural control, is a little bit different. So thanks for your question. All right, any other questions? All right, so thank you again for all taking the time to attend the seminar, and I hope it was informative, and I'm happy to see you or our other urogynecologist, Dr. Ashford, at Minnesota Women's Care. And thank you again to Medtronic for putting on this talk and helping the attendees to get here to hopefully learn more and improve their bladder and lifestyle. So thanks all again, and I'm going to sign off the seminar. So thanks again.